Welcome, everyone. Dr. Chris Sapienza here for our Aspire Respiratory Products Wednesday webinars. We're just going to wait a few minutes while all the participants get themselves loaded up through the internet channels here. We're excited about tonight's talk, Speech and Pulmonary Medicine. A great colleague and friend of mine, Dr. Danny Pulido, MD, is going to be speaking with you tonight. We'll do some introductions here in just a minute. I appreciate the patience for those of you who are waiting in the wings. I think tonight we're going to have so many questions answered by Dr. Pulido about this burning inquiry that we have and worry sometimes that we have about the interactions between the heart and the lung, making sure that respiratory strength training devices that we're using are not harmful to our patients, or if there's any contraindications that we are aware of them. So we'll get started here in just another minute or so. Vicki Bell says, good to see you again, Dr. Pulido. I know it seems funny that a minute is a long time to wait when you're waiting, but in that 1 minute, 6 or 7 people have joined on, so I'd like to start right at the start time. So again, folks, it's 5:30. I'm Dr. Christine Sapienza, and I'm moderating the session today held by Aspire Respiratory Products on our Wednesday webinars. We're here with Danny Pulido, MD, talking to us today about speech and pulmonary medicine. And as you can see from his credentials on the slide, Danny is a pulmonary and critical care specialist. He's also the medical director of Baptist Beach's Pulmonary and Critical Care. He's also the medical director of Jacksonville University's Respiratory Therapy Department. And there's a rehabilitation long-term care facility and skilled nursing facility called Dolphin Point Rehab that he oversees. And new to Jacksonville is the Lake Erie College of Medicine, which will begin enrolling medical students in 2026. And Dr. Pulido will be serving as the clinical dean. So with all that, Dr. Pulido, you are wearing many hats. You're a very busy physician. And I just want to personally thank you for taking some time, because as you know, as speech pathologists and respiratory clinicians, oftentimes we get a little worried about what's actually happening, when we use these pressure threshold strength training devices. So tune in, everybody. Let's listen to Dr. Pulido, and we'll have some times for questions. Thanks again, Dr. Pulido.
Thank you very much, Dr. Sapienza. Can you hear me okay? Excellent. Perfect. Well, thanks again, everybody, for allowing me to speak today. It's an honor, and excited to talk about this topic. There is some videos that will be interesting to see, and I'll kind of explain the effects both in the physiological forms and then some pathological scenarios on how positive pressure and negative pressure, for that matter, in the thoracic cavity can affect the heart and lungs. There will be some basic just kind of overlap of anatomy, physiology of upper airway, lower airway structures, and then some effects on how oxygen and humidification plays a role into that. But for the most part, I think, as I kind of dive deeper into the topic and the goals of this presentation, I really kind of see that the focus of this is really the physiological effects of pressure changes in the thoracic cavity itself. So with that aside, I'll just go ahead and get started. And make sure I get the slide deck moving. Perfect. So the general anatomical spectrum here, from upper airway nasal passages down to from nasopharynx, oropharynx, the larynx, then the lower respiratory tract tree with the trachea, the bronchioles, and then the bronchioles, and then the terminal bronchi, which ultimately lead down into the alveoli, and then the capillary beds that are surrounding each alveoli. From top to bottom, there are factors of why, and the physiological changes that occur and muscular structures that are supporting these anatomical structures that all have a variety of different effects in our physiological state of mind, but also then you have to take consideration how these effects can be utilized, both optimized during a pathological state in which we're trying to treat patients with different devices, different drugs, different oxygen therapies, different humidifications, to make sure we're really doing the best for the patient and not doing harm. Because if utilizing the wrong technique, unfortunately, harm can be done even in the best intentions. So just as a recap and refresh, we'll look into the structures in and of itself separately. But as you may already know, the internal and external the respiratory efforts and respiratory motions, all of which are driven through the thoracic muscles. And the main one that really drives our respiratory effort is the diaphragmatic muscle, which is really a key to respiratory effort. There are intercostal muscles and thoracic muscles that attach and facilitate respiratory flow or thoracic changes. But the number one factor for our respiratory effort really has and always will be is the diaphragm. So as you can imagine, diaphragmatic lesions, whether direct to the diaphragm itself or indirect, patient has had any kind of mediastinal surgery, the most common being a cardiothoracic surgery, or has had any kind of neck surgery for which the phrenic nerve can be damaged or lacerated. If you have phrenic nerve damage, you can get a paralyzed diaphragm. Typically, it's unilateral, and if it's obviously bilateral, it'll be catastrophic, and you'll be looking at some type of respiratory assisted device to help those patients along. But just aware that those are scenarios that we commonly see, given that open heart surgery is very common, and we do look for that post-operatively, and afterwards in clinic, you'll see changes in the diaphragm that are suggestive of that. The respiratory effort, as we breathe in through a negative pressure, and we'll talk a little bit more about that with some more interesting videos. But aside from a pathological state, normal physiology, we suck in air like a vacuum due to the diaphragmatic contraction, causing a negative pressure thoracic cavity, and that negative pressure will essentially suck in air through our upper airway nasal passages, or mouth for that matter, and air then fills into our lungs, and the gas exchange occurs. The relaxation of the diaphragm and the intercostal muscles will then allow for the change of thoracic pressure to go from negative to neutral. It doesn't really go to 100% positive, but that neutral effect of pressurization will allow for the exhalation of gases on our exhalation phase of breathing. Upper airway passages, as you can see, the nasal pharynx has a variety of different anatomical structures that are important for improving or optimizing air to mucous membrane contact surfaces. For the reasons of these confides, that having air passages into the different mucosal membrane allows for the beginning process of heating and humidification of the airway itself. Of the air itself. As the air passes down further into the lower airway tract, the continued humidification and heating of the air will allow for smoother and easier gas exchange when it gets down to the alveoli level on the capillary beds. But things to consider and be aware of when assessing patients, and I recognize that this is a speech pathology audience. When I see patients in the hospital setting, specifically as they're transitioning from inpatient, med-surg, PCU, and transitioning to an ICU bed for worsening respiratory status, if this patient has been on a high oxygen concentration, and specifically if they've been on high concentration, even more so, even like a BiPAP, I commonly watch for and look at when we take the BiPAP mask off to do an airway evaluation and examination, has the mucous membrane has already occurred to an extreme dryness effect, where mucus in the throat or in the back of the oral pharynx has actually started to congel and or become more of a kind of fixed solid mucus plugs that can cause airway compromise. So humidification is very important in respiratory therapy, especially when in an acute pathological setting, for which oxygen is delivered when utilized more than nasal cannula liter flow. Once we start going into higher oxygen concentration flow with higher flow rates, one of the more common devices that are utilized is a kind of a high flow device. has been vital that this type of therapy is always in conjunction with humidification to make sure that mucous membrane stays nice and moist and not damaged. On a side note, when winter season comes around, common colds occur more so during the winter months for a variety of reasons, but one of those reasons is the mucous membrane that dries up. And I'll come back to this slide in a second, but this is what I really want to emphasize. As the heat and humidification effects occur, as the cold air starts to warm up and go into the lungs at the core body temperature of 37 degrees Celsius, it improves and allows for better gas exchange. But this humidification is what really allows for microcilii, that is the lining inside the mucosal airways from the nasal pharynx all the way down to the terminal bronchi. That's our local defense mechanism that helps expel dust particles, viruses, bacteria, or things that we might be inhaling at different times. Cold air will cause local damage to these cilii, same as you would get if you're in the winter months and you get dry, cracking lips, chapped lip that you would typically see in cold months. That same dryness of the mucous membrane of the lips will occur in the airway and cause a displacement or damage of this microcilii, and technically losing your first layer of defense and allowing for bacteria and viruses to introduce itself easier into the other layers of the mucosum. So the importance of humidification is key in a pathological state, but in the winter months, just be aware. And that's why heated humidification or humidification in general has always been a good remedy at home for those type of scenarios. But going back to some other physiological changes that I think will be important. When we talk about pressure changes in the lung and the respiratory system that are either being manipulated or being altered due to devices or therapies, we have to take in consideration the dynamic effects that it's causing, not only in the respiratory system, but in the cardiovascular system too, because obviously the heart and lung share in the same space. There's going to be a change in, you may or may not have heard this term before, but what's called dead space. And dead space is essentially the space of the lung that is not being utilized for gas exchange. So technically, dead space is from the tip of the nose down to about the terminal bronchi before the actual alveoli occur, because that's where gas exchange occurs. So in this portion of the respiratory tract, there's no gas exchange. So it's technically considered dead space, whereas oxygen that comes in, if it doesn't make it all the way to the alveoli, that oxygen will just go back out with exhalation. So another effect of pressure changes when treating somebody who's in distress, if they're, for a variety of reasons, very dyspneic and trying to catch up on their breathing, if you can supplement that with positive pressure therapies, that will improve patient comfort. It will improve oxygenation. And we've already touched on hydration as an important effect. So talking about pressure changes on the lung in regards to tidal volume and inspiratory and expiratory time frame. When breathing under normal circumstances without any type of pressure changes, inspiratory time values and, can you see my mouth there? Inspiratory time values and volume over time are very small and subtle, but in a normal physiological healthy state are suffice to maintain our adequate physiology for oxygenation for the lungs. But when somebody's in an acute pathological state and is in need of more respiratory support, the added positive pressure can allow for a larger inspiratory breath, but of a prolonged expiratory phase that allows for what's called recruitment and improved aerolization of these alveoli to allow better and prolonged gas exchange effects, both of the oxygen and CO2. And this has been proven under physiological studies when looking at rapid shallow breathing under pathological state without positive pressure, and in rapid shallow breathing with positive pressure. When patient in a normal without positive pressure breathing status, if they're dyspneic and trying to catch their I guess for lack of better words, kind of catch their breath and get their oxygen status in a better condition, you can see very shallow rapid breathing. once positive pressure is added, larger tidal volumes, larger effects, and the rate of breathing is slowing down. So you can see already how just change of pressure will change the patient's breathing, physiology, and then overall, ultimately, comfort and with all efforts to improve the pathology effect. We talked about the hydration. We talked about dead space. Now let's talk a little bit about more going into the larynx and the anatomical structures, and more so muscle structures and the chordae itself. This is what I was referring to when looking at patients that have been in the hospital setting or have had difficulty with breathing, requiring oxygen supplementation, and they're either A, voice changes are starting to occur, or B, their oxygen needs are starting to climb. As we're transitioning these patients to the ICU, when looking in the back of their throat, you'll see sometimes these patients have extreme dryness in the back of their throat from oxygen use, and that can cause mucus to actually congel and cause thick plugs there. So things to watch out for when evaluating patients for any kind of swallowing and or voice changes. But another important point that I'm sure you guys have clearly been trained and hone in to look for is vocal cord damages, vocal cord paralysis, vocal cord dysfunction, and any kind of vocal cord pathology. We're not going to talk about the pathological conditions that occur that can cause vocal cord damages, but I think in the purpose of the presentation with the different type of therapies and devices out there that might help improve muscle training, this can be of a great effort, and what we have actually found by utilizing a lot of our devices, or the EMST devices and the IMST also devices in our pulmonary rehab patients, just alone in speech and vocal cord sense and function and swallow and cough, the implementation of these type of devices, we have found subjectively had clinical improvement. There's, to my knowledge, no way to show objective vocal cord strengthening except for fees and looking at structural changes, but subjectively improvement in cough and strength and has been noted, at least in our pulmonary rehab center at Dauphin Point. And to the point being that although vocal cord nerve injuries will not be enhanced with therapies, but the surrounding muscles, like any injury, although permanent nerve damage can be done due to whatever variety of causes, surrounding muscles can elaborate and collaborate and cause a collateral strengthening of function, and over time can allow some better protection of the airway when eating and drinking, if that's the case. So going down the lower respiratory tract, the trachea and the bronchi, as you can see, this animation shows a good depiction of ventilatory flow of gas particles, typically oxygen being the one. And like any fluid, whether gas or liquid, it's going to go through the path of least resistance. You may or may not be aware of the lung zones. The lungs divided into 3 zones: the upper zone, the middle and lower zone. Upper is predominantly higher air gas exchange, whereas lower zone, the zone 3 has a higher density of vascular blood flow, and the middle zone, zone 2, is the ideal combination of gas exchange and blood flow. Obviously, blood flow being of a higher density and gravity being the main effect here, you're going to have larger volumes of blood in the lower lungs, and on the upper lungs, you're going to have a larger concentration of gas exchange with less volume of blood flow. So that's just a general note of pulmonary physiology, but knowing that will help interpret pathological conditions and how to change pressure and devices that can affect more so that when we talk about the heart and the lungs and how that will work, and I'll show that on the video here coming up soon. But looking specifically at the bronchi when talking about pathological structures, pathology of the bronchi, we're really looking at obstructive lung diseases, and that most classic is going to be asthma versus COPD. And then back in the day when I was in med school, we were kind of trained that it's either one or the other. But in reality, more so, we're finding that it's a spectrum of obstructive lung disease, and it's really within this spectrum that they could have the intermittent obstructive asthma components. but it can proceed into more of a chronic obstructive component, depending on the cause, the triggers, and the injury itself. In the intermittent obstructive component, specifically more in the asthmatic patients, it's a very high dense muscle contraction of the airways that causes bronchoconstriction and the reduction of airflow through limited lumen capacity. It's hence the use of therapies such as bronchodilators will help improve this. But there are also other problems associated with obstruction, such as inflammatory changes that causes swelling of the airway. And then the last is mucus production due to chronic irritants such as tobacco or any work-related irritants that will cause an overabundance of mucus production, and that mucus in and of itself can cause obstruction of the airway itself. So there are a variety of treatment strategies, but just be aware of the bronchi itself is loaded with musculostructures, both transverse and cylinder type muscles that rely on relaxation, contraction for airflow throughout the lower respiratory tree. As I mentioned, there's a variety of inhalers. We won't get into any of this, but just so you know, there's different classes of inhalers, whether it's an inflammatory type of syndrome that you're going to use more steroid. We already mentioned the bronchodilator, which is a beta agonist type medication that stimulates muscle relaxation and improves the bronchodilation. And the third is the anticholinergic or the muscarinic type of inhaler that really reduces the mucus production. Fortunately, now we have triple inhalers that really gets all three classes in one inhaler. So in those type of scenarios, triple inhalers will be a great medication to use. Switching gears a little bit when looking at pulmonary pathology, the prior obstructive lung diseases is predominant of the airway itself. There are some also about alveolar obstruction due to emphysema, but for the most part, think obstructive as an airway problem. And then switching gears to a restrictive problem is due to the inability to get air in the lungs. And that classically, a great picture here on the bottom right, you can see there are a variety of reasons for which the lungs could be restricted. And I like to classify this as intrapulmonary or extrapulmonary. Intrapulmonary is a great example of that is your dreaded pulmonary fibrotic patient, where fibrosis of the lung occurs, and as the inflammatory changes of fibrosis progresses, it causes a reduction of lung elasticity and capacity due to scarring of alveoli and then bronchi, at which point, if not, and unfortunately there's no specific treatment for this. There are some medications that have been found to slow the disease down, but there's no cure for this. Unfortunately, the ultimate progression of IPF will likely land somebody in a transplant center for lung transplant. But the extrapulmonary restrictive defects, for which is what we commonly see more often than not, are factors that have to do with structures that are pushing on the lung. The lungs themselves could be healthy, but whether it's a body habitus issue or whether it's a cardiac issue, and I mean by cardiac, it could be cardiomegaly, congestive heart failure with an enlarged heart will cause, due to the space limiting the heart and lung. If the heart is expanded in size, it's at the expense of the lung. If there are other structures inside the thoracic cavity, such as pleural effusions or pleural disorders, that will also restrict the lung. The lung itself is still healthy, but the capacity to stretch is going to be limited in restrictive lung diseases. So the one last bit on the kind of the physiological effects of pulmonary function. As we breathe in air and the oxygen in the air goes down to the alveoli component, from the terminal bronchi to the alveoli. Here, the alveoli is capillary bed rich layers of blood vessels that go around the alveoli. Oxygen diffusion occurs through this membrane. It is picked up through red blood cells. Oxygen does not freely float in the blood, although CO2 does. So CO2 then diffuses out through the blood into this alveoli membrane and is expelled out with exhalation. And this process is our normal physiological effect. Although this animation shows a good job of showing the gas exchange, the portion that it does not show, and you just have to use a little bit of your imagination, the alveoli are expanding and contracting with ventilation, and that expansion and contraction with ventilation, it will have effects on the capillary bed. Think of the capillary bed as a spongy, small tube that as the alveoli expand, it will cause some compression of those capillary beds. And as that alveoli exhalation occurs, those capillary beds will slightly engorge a little bit and allow for optimal, better flow. So that in a normal physiological situation will have some degree of capillary diameter exchange that happens during inhalation, exhalation. But when you add positive pressure or negative pressure through the respiratory system, you will have exaggerated effects in the circulatory system itself. And with that, I do have two neat videos that will help explain these type of effects that I think will be vital kind of understand this. So I apologize. Let me just switch over real quick. So I'm going to play this video here. This is one that just talks in general about the cardiopulmonary respiratory mechanisms on how that changes the blood flow and the negative and positive pressure in the lungs. Now, this video I did, obviously it's produced by Zoll. Zoll is a manufacturer of our cardiac defibrillating devices that we use in the hospital, particularly around resuscitative effects, AED or our defibrillator and some of their mask devices that we use during CPR. But they did a phenomenal job with an animated video that really hones in the positive and negative effects of respiratory motion. So I'll try my best to skip any product and go straight to the actual video itself.
Recall that during inhalation, we create a slight intrathoracic negative pressure or vacuum that draws air in, returns blood to the chest, and slightly lowers ICP. During exhalation, a positive pressure forces air out, inhibits preload, and slightly raises ICP. With an ITD in place, the patient breathes in through a slight amount of therapeutic resistance, which enhances.
Now, pause for a second. This device, which is the ITDs, it's an intratracheal kind of device. We're not obviously talking about this device in general, but this particular device is talking about airflow restriction on exhalation. So this goes to the fact that if you start to affect expiratory and or inspiratory pressure changes, this is the effect that it will have on the cardiovascular system.
The negative pressure in the chest. This greater vacuum results in increased preload, cardiac output, and blood pressure, which is essentially the opposite of CPAP. ICP is also lowered, which is a distinct advantage over fluid therapy.
ICP is intracranial pressure. So it talks about also improving the intracranial pressure.
Studies show that when the brain is under pressure, poor perfusion results. Breathing through an ITD has been shown in studies to lower ICP and improve cerebral perfusion pressure. During use, most patients tolerate the slight resistance created by an ITD during inhalation, and there was no significant resistance to exhalation.
So this ITD that they keep referring to would be the equivalent of the inspiratory muscle strength training device. You basically would be breathing under that certain kind of pressure threshold that is set with this device. Now, another interesting video that I thought would be very important to show that kind of goes alongside with what we're talking about here.
Recall that during CPR, positive pressure helps to circulate blood forward, while negative pressure, or a vacuum, helps to refill the heart. The rescue pod fits into the airway circuit with a face mask or advanced airway.
The rescue pod is a device that Zoll came up with to allow air to go in, but minimizes the air to come out.
During chest compression, the ITD's valve opens and air is forced out of the body and through the rescue pod without resistance.
I apologize. It was the opposite. It allows air to go out easily, but doesn't allow air to go in unless forced to the airbag.
But as the chest wall recoils, the ITD's valve closes and selectively prevents air from being drawn in. Preventing the influx of air enhances the negative pressure, which pulls more blood back to the chest and heart. Increased preload results in increased cardiac output on the subsequent compression.
Now you might say, or you might ask, if you're not allowing air in, how are you ventilating this patient? What this particular device does, you can allow air in when you override it with the ambu bag, but when chest compressions are occurring, we're not giving breath every single chest compression. Obviously, we're giving chest compressions. We're giving ambu breaths about it's supposed to be 10 to 15 breaths per minute. So when you compress the ambu bag, it allows, it's a pressure threshold device, will allow for airflow to go into the lung to ventilate. But at the time where the ambu bag is not being compressed and the CPR is in effect, this is what is showing that negative pressure in the thoracic cavity that is starting to build up due to lack of ventilation or of a tidal volume breath will allow for an optimized or improvement in the preload, which is volume coming back to the heart.
This enhanced vacuum also lowers ICP, which enhances blood flow to the brain.
All right, so those are the two bullet points I wanted to hit with the videos. So in essence, respiratory therapy, the effects both on the physiological effects when cardiopulmonary pressures are changing through the respiratory cycle. When adding a device, whether it's a pressure device or oxygen therapy or humidification, there will be effects that will occur, both enhancements that we are attempting to achieve, but detrimental effects that would also need to be considered and recognized to make sure each device is appropriate for each type of therapy. To emphasize, I think the point that I want to make tonight is that when using some degree of a pressure, like a expiratory or inspiratory muscle training device, if in the right setting, can help optimize blood flow back to the heart, optimize circulatory flow through the lungs and through the coronary system, and then help optimize the ventilatory effects with recruitment of the tidal volume itself. So allowing kind of longer, prolonged optimization of lung volume in the right setting. In the wrong setting, if somebody's in an acute distress, is in fighting an actual acute infection, if you restrict their airflow, it can cause more distress, can cause a reduction of cardiac function, and potentially cause other concerns there. So in the right setting, obviously knowing the patient well, knowing their past medical history, their cardiac history, their pulmonary history, in addition to their upper airway history, whether it's vocal cord injury or nasal injuries to consider. These different things are all taken into consideration as to which therapies are optimal for what type of disease state you're trying to improve. Also, just recognize there's a variety of other causes of shortness of breath. So in one important point I always try to emphasize to patients is that medications and a variety of different device therapies all do great, But one of the most important parts that I can't emphasize enough is the general exercise of getting out and using other aspects of your body for oxygen utilization. One of the things that I always kind of hone in with the med students is that it's different if somebody's short of breath and they're a couch potato versus somebody who's short of breath and they're very active. The oxygen molecule that is carried through the red blood cells is at a fixed limited rate in a normal physiological state without anybody with any kind of hemoglobin pathology. The oxygen diffusion from the lung to the blood system, for the most part, is going to be in a fixed state, given aside from any kind of acute infection or acute pathology. What can be altered in oxygen utilization is the actual oxygen breakdown and production of energy, which is ATP. We produce about 36 ATPs from every oxygen molecule that enters a cell. And when somebody is in shape, which is the main reason why athletes train, like any cell or any organism that is utilizing a part of their body that they feel is in need and they need more of, the body has and the cell has the capability of up-regulating more receptors or intracytoplasm organelles, such as mitochondria and a variety of other factors that could be up-regulated if the body feels like it needs it. If the body feels it doesn't need it and the patient becomes inactive, or if a patient stops taking a medication, the body will actually deregulate or decrease different factors. Receptors can decrease in amount. Organelles intracellular can decrease in amount. And the most important one here is the mitochondria. Oxygen molecule in the mitochondria in a healthy state can produce, as I mentioned before, 36 molecules of ATP, which is essentially our fuel for muscle to work. And in shape patients or patients who exercise on a regular basis are going to have a lot more mitochondria in their cell, because the body recognizes that this is of need and this is what the patient's body is needing. But if somebody is out of shape, despite having a healthy pulmonary function, healthy amount of red blood cells circulating, but if their mitochondrial content in their cells are diminished or minimized, the amount of ATP being produced is going to be very little. And the time of need, if there's ever a need to run out of a burning building or walk up a flight of stairs or carry your groceries from the car to the house, the cells, the mitochondria, because they're not upregulated, will not have the capacity to upkeep the amount of oxygen energy needed for cellular function, for which muscle distress occurs, anaerobic metabolism starts to occur, which causes then muscle injury and so forth. So the importance of recognizing shortness of breath is not only a pulmonary problem or a cardiac problem or a circulatory problem, but it could also be a deconditioning problem. And patients need to include a healthy exercise routine in their regular therapy options when trying to get better. And with that, that wraps up my talk, and I appreciate the time, and I'll take any questions.
Thanks, Dr. Pulido. That was absolutely wonderful, and the images are very striking. And I know we're trying to condense such a large amount of information and really come home with a take-home message. Tonight we're probably joined by a lot of speech pathologists. I think we have some respiratory therapists on, maybe some physical therapists. So I want to take what you talked about and ask a couple of key questions that I think are burning inside of clinicians' minds. So bear with me a little bit while I fire away some questions at you. You did a fascinating demonstration about really inspiratory muscle strength training and how it can drive cardiac output. I think that was a big take-home message. And you also just at the end here talked about the importance of physical exercise, right? And the benefits of aerobic respiration. My first question is, we tend to use these devices when there's pathophysiology. Do you think there's application here for just training, fitness of the lung through, let's say, an inspiratory muscle strength training process?
Oh, I definitely think so. I mean, if anything, it's just if anybody's just trying to optimize their body mechanics, there's a variety of different other therapies. We have professional athletes who use oxygen at high exercise training. So and we see that in some of the games themselves on professional TV. Some therapies that are being utilized. So this muscle training devices that are out there that clearly I think will have benefit of strengthening muscle overall, allowing for optimization of just general physiological conditions that can occur and help them battle any kind of stress or pathological state that they might incur in the future.
Right. So big, I think just for the audience, big opportunity here for prophylactic and I'm never going to claim any anti-aging, but certainly we know what's happening in the aging system, and we have to be able to combat that muscle atrophy that's occurring and that change to lung elasticity, et cetera. So thank you for answering that question. One that comes up all the time, I think, is, do no harm. We want to be sure as clinicians that we're not potentially loading, too much onto a patient. So for example, these thresholds on these inspiratory and expiratory devices can go as high as, 75 centimeters of water pressure up to 150 centimeters of water pressure. And what we find is patients continue to increase as they train and they get really rapid changes in muscle adaptation. Is there a level, where you would say for somebody that has chronic obstructive pulmonary disease, or maybe you're thinking of a cardiac, pathology, and you say, whoa, that is too high, and you're going to put somebody at risk, and you need to be at a much lower pressure threshold because of a contraindication?
I wouldn't say, it's a great question. Off the top of my head, I can't put a number as to this number, don't go above X. But I definitely want to emphasize the two big components that would be of concern. That is the importance of, speech therapists monitoring these therapies on the initial onset of implementation, just to make sure that the patients are doing them accurately and correctly and safely, but B, to assess the first couple of therapy sessions if there is any notable physiological changes that start to occur. We talked about how pressure changes, that thoracic pressure changes can affect the preload, which will increase volume to the heart. You do have to recognize that sometimes increased volume to the heart can cause detrimental effects. The more common cause of atrial fibrillation is a dilated right atrium. So, and if you're increasing preload volume to the heart, the first chamber of the heart is the right atrium. So if you are noticing, I could see how implementing this to a very high restrictive component, causing increased thoracic pressure changes on somebody who's probably a little bit on the fluid positive side of their overall fluid status, and they have a history of maybe atrial fibrillation or predisposition to atrial fibrillation. Something of that scenario I could see occur, but I don't want to say a specific number. It's just know your patients well, know your history well, and know what to look for. And I think parameters that would be wise to be checking while implementing this type of therapy would be, obviously a fresh set of vitals prior to blood pressure, heart rate, O2 saturation. If you have the capability, I think it would be neat, and this is how we do it in our therapy sessions, the capability of doing a pre-spirometry and a post-spirometry with every session to see over time the tidal volumes that occur, the changes of tidal volume, the changes of expiratory flow. Ideally, you would like to see progression. Another scenario that would be of concern would be somebody with advanced obstructive lung disease like COPD. If they're in their baseline state, despite having severe disease, but in a baseline state, potentially would not cause harm if you're not excessive in the therapies. And like always, any therapy should always be started, easy and light and progress as they go over time. But I would not try to implement this. We wouldn't do this to somebody who's being hospitalized in an acute exacerbation and try to say, okay, start using this device.
Right.
Over their exacerbation first.
Yeah, and I think you were very clear on that. Acute, inflammation, infection. Certainly showing what some of those potential harms could be. And I think you made another great point on the advanced COPD. the literature is showing that when we train with inspiratory muscle strength training, they're actually having, cutting in half what would be the typical pressure threshold. We typically base respiratory muscle strength training on the baseline MIP or MAP, and they actually cut that in half for COPD. I think to do exactly what you just said, kind of ensure that you're not straining the airways or causing, further collapse. But I have to ask you, and maybe help us out a little bit more on the cerebral perfusion slides that you talked about. We're working with patients that, a lot of us are working with patients that have stroke. And somebody, obviously in the acute phase, 2-3 days in, there's a lot going on. But now 2-3 weeks have gone by, 4 weeks have gone by, the patient's stabilized. What kind of questions might a speech pathologist be asking the pulmonologist, be asking the neurologist, when we're talking about the potential to use IMST or EMST for swallow or cough disorders? But, this person just had a cerebral infarct. Are we potentially making a rise in intracranial pressure? Could that be a contraindication we need to worry about when we're blowing against the device? We're doing a mini Valsalva that only lasts a couple of milliseconds. Any concerns there?
There are pros and cons to consider. We do in an acute setting when we have a code stroke alert or we have identified a stroke patient in the acute setting in the ICU, we do hyperventilate. Hyperventilation has been found rapid reduction of CO2 lowers intracranial pressures, which helps improve cerebral blood flow. So I can see how the devices, by improving ventilatory effects through respiratory muscle training, can reduce CO2, can have the effects of improving intracranial pressure. But I can see how on the flip side, any kind of therapy, especially like expiratory muscle, either extreme, inspiratory or expiratory at a high level that's causing extreme level of pressure changes that you're using accessory muscles to try to achieve, could likely cause stress to a certain degree that can cause more like a vasoconstrictive effect that can raise, I would imagine, I don't have a study to prove it, but I would imagine my professional opinion would be it could potentially cause a little bit of distress on circulatory system in general. I won't go as far as saying specific to the brain, but in general. So we know reduction of CO2 in an acute situation improves cerebral blood flow, but at the same time, if you're adding therapy, which by definition, if it's going to be a long-lasting therapy, you do need to push the therapy to the point where it's like exercise, anything. You don't really do a whole lot of exercise. You're not going to get better if you just go to the gym and just kind of walk around for a little bit. The more you push yourself, the more the muscles are going to get better. So it is a catch-22 on you do want to get the benefits of doing the therapy, but you don't want to push it too much that it can potentially cause harm. And once again, I can't off the top of my head tell you a number as to
No, I think you're saying the right thing. I mean, it's common sense, and you're not using extremes with these patients. They're in acute situations. They've just had a particular incident occur. And, I always say to individuals, they also look at what the bowel is doing and how they're moving the bowel. And, because you're going to be doing Valsalvas during bowel movements as well, and sort of look at the normal biological functions and always, have that conversation. What we're trying to teach our clinicians to be really well educated what these devices are and do, and know those pressure ranges so they can have conversations with people like you. What about pneumothoraxes, Dr. Pulido? Can you tell us a little bit about a pneumothorax and how that might be a contraindication?
But one last thing to go back to on the stroke that I think was important, because although the speech therapists clearly are active, we get our PT, OT, and speech automatically with any stroke patient in our acute care settings, and then on the post-acute care or rehab settings, obviously that continues depending on their progression of therapy. But clearly the need for speech in a stroke is the risk of vocal cord injury and aspiration to follow afterwards. I always tell patients, unfortunately, in the ICU, the most common cause of death in a neurological patient is aspiration pneumonia.
So the cool thing that most of our listeners are aware of is that EMST has now been, a highly well-studied device that improves swallow musculature, that reduces penetration and aspiration. and also aids voluntary and involuntary cough. And that's stuff that we've covered and talked for another time. It's very heartening to hear from you as somebody who's working so closely, you know, with the lungs and knows the physiology of the cardiac output. And I'm just, what we're learning today about cerebral perfusion is really additive, I think, and advanced to the individuals that have been on the talk. I have one other question here from Joanne. Let me see if we might have already covered it, but let me read her question out loud. It says, you said that lowered ICP increases cerebral perfusion, yet our neuro allow increased BP for perfusion with our stroke patients.
Yeah, that's a great question. So what that means there, what they're talking about there is in an acute ischemic situation, you don't want to lower the pressure too low in a brain setting, because you have to take consideration more often than not, patients who've had a stroke, they either A, have hypertension, or B, in an acute ischemic stroke or area of injury, a vascular injury to the brain, there's going to be vasoconstriction that is starting to occur in that part of the brain. So naturally you want to improve perfusion, but if you decrease intracranial pressure, you do want to decrease intracranial pressure, but you have to be very careful about not decreasing cerebral perfusion. You do want to increase cerebral perfusion in an acute stroke. And I'm talking about in the first 24 to 72 hours, because if you reduce cerebral perfusion, vasoconstriction causes obviously worse harm, further damage, further ischemia. So in an acute setting, if a patient comes in with a blood pressure, for example, 200, actually we had this discussion today in ICU rounds. If somebody comes in with blood pressure 200, you don't want to leave them with blood pressure 200, but you don't want to reduce their blood pressure, their systolic blood pressure down to 120 either. We do want to have a reduction of systolic blood pressure around 20% in the first 24 hours to allow some reduction of perfusion and the capillary and the cerebral bed, but without causing a vasocapillary collapse. So in the neuro ICU, it's a delicate balance of intracranial pressure and cerebral blood flow pressure. If the intracranial pressure is naturally going to be elevated, say for example, like a hemorrhagic stroke, now it's a space occupying blood product that's filling up the skull and it's putting pressure on the brain. That's causing intracranial pressure. You want to combat the cerebral pressure, because if you don't combat it, the intracranial pressure will overcome the cerebral pressure and you'll get more ischemia. You want to combat the cerebral pressure in that patient. You want to actually give pressors or give more saline and blood flow to allow that combation to that battle of pressure and kind of ideally meet a kind of a happy medium between the cerebral pressure and the intracranial pressure. So it is really you're splitting hairs there once you start getting into that acute stroke situation. But that ideally you're in a neuro ICU where you got intracranial device monitoring, so you can measure active pressure changes and treat on that effect. And then we're monitoring the cerebral perfusion through separate devices, and we're adjusting for that. But I don't think speech, nor do I think these any type of respiratory devices are going to be utilized in that particular situation.
Agree.
That's your first 72 hours of an acute stroke. I mean, there are a variety of other much more important, bigger problems that they're dealing with.
Yeah, you're not going to be whipping out a IMST or EMST during that time frame. But that's a great question, Joanne, and thanks for clarifying it. I'm going to wrap up with just one other question, and that you showed an image where you were looking obviously at the radiographic images of the lungs, but noticeably one of the patients was pretty obese. And can you explain to the audience a little bit about that chest wall load and how respiratory muscle strength training might actually assist this person with dyspnea, because there's a tremendous amount of load on the chest wall with that additional fat.
Yeah, let me go back to that slide. It's a great question right here. So a variety of factors that will play a role regarding the thoracic cavity flexibility and contraction and relaxation during the respiratory motions. So yes, the body habitus will cause a pressure gradient on the rib cage itself, causing a more restrictive and resistance or higher resistance of to allow that rib cage to expand. That's going to be one. The biggest one of a patient of a higher BMI that you classically will see, and where the patients really kind of get the aha moment, is when we talk about overweight and how that affects their breathing, especially when we're talking about abdominal girth and their abdominal distension. As we gain weight, commonly the first thing that starts to happen is our abdomen starts to progress anteriorly, more forward. What's happening internally that patients don't recognize, in my office, I have a similar diagram of just a general anatomical picture of the heart and lungs and the diaphragm. But as we gain weight and the abdomen goes forward, what's also happening internally is our abdomen is going upward. And in doing so, it's actually pushing the diaphragm higher up. So as you can see, normally you should be able to count about 8 to 9 ribs of lung anatomy or lung tissue space before you start to see abdominal structures. Such as in this patient, you can get easily about 9 ribs counted before you get to 10, 11, and 12. Once you start to gain weight and the abdominal pressure starts to increase, it does so at the expense of a rise in the diaphragm, and that does so at the expense of a collapse or a reduction in total lung capacity. So right there already, just in general, a patient's already behind the 8 ball and that's just at rest, much less with exertion. And where they really get the aha moment is I ask them, do you clearly feel more short of breath when you bend over to tie your shoes or put your socks on? And they say, I can't do that anymore. And doing so, when you bend forward, you're pushing your abdominal structures and your organs even higher up. And that's why after bending forward, you have to sit back up again. It takes a little bit to catch your breath. And what's happening is you're essentially allowing for recruitment to occur, and that recruitment pushes the diaphragm further down. So yes, there's definitely importance of not only weight loss and exercise, but B, there's a significant improvement when muscle training starts to take effect, and that diaphragm tension is strengthened to the point where it can combat this abdominal pressure.
Sorry, I was on mute. Excellent. I tell you, I hope the audience has found the clarity of your responses to some really common questions really helpful. For the group, visit emst150.com, go to the healthcare professional site. You'll find an ability there to register and log in and access not only Dr. Pulido's recording, but previous recordings we've done. We look forward to another Wednesday webinar at the end of March, and you'll see some marketing materials on that and have another great speaker. Dr. Pulido, thank you so very much for joining us and sharing your expertise and your time. We know you're a very busy person. You are getting great compliments from the chat, and everybody's really excited to have had you on this evening. Thank you so much.
Thank you.
Good night to everyone. And if you have any questions, just email questions to questions@emst150.com, and we'll be happy to answer them post Dr. Pulido's talk, or reach out to him for any clarifying answers we might need. Thanks, Dr. Pulido. Great to see you.
Likewise. Take care.
Bye-bye. Thank you, everyone.